Good morning and good afternoon, everyone. On behalf of the National Collaborating Centre for Indigenous Health, I welcome you to today's webinar, Visioning the Future Public Health Series. This series focuses on our National Indigenous Organizations here in Canada. My name is Margot Greenwood. I am the academic leader of the National Collaborating Centre for Indigenous Health. Our centre is located at the University of Northern British Columbia in Prince George, BC. I begin today by acknowledging the ancestors and traditional unceded territories of the Métis people and thank them for allowing us to work, live, and play on their lands. Visioning the Future is a series of webinars presenting a vision for First Nations, Inuit, and Métis Peoples public health. These webinars are a development of the NCCIH's 2021 publication, Visioning the Future, a collaborative report offering a vision for Indigenous peoples' health and well-being. Privileging Indigenous knowledges, the commissioned report complements the Chief Public Health Officer's 2021 Public Health Vision Report entitled A Vision to Transform Canada's Public Health System. Today is the series' third webinar. Next slide, please. Very briefly, the NCCIH is one of 6 national collaborating centers for public health that was established in 2005 with funding from the Public Health Agency of Canada. Our sister NCCs are focused on specific areas of public health, including infectious diseases, environmental health, healthy public policy, determinants of health, and methods and tools for knowledge translation. Our center supports health equity for First Nations, Inuit, and Métis peoples by promoting the use of Indigenous-informed evidence to transform practice, policy, and program decision-making across all sectors of public health. A couple of logistical points are on this next slide, and you can see them there. I encourage all questions for the panelists, as well as technical questions, can be submitted to the Q&A window. There'll be links to resources that are mentioned by the speakers will be posted in the chat window for you. And today's webinar, just so you know, is being recorded and will be available on the NCCIH website. There may be, as we switch between speakers, there could be some pauses, so don't think that we've left you. We have a series of learning objectives that really follow along out of the Visioning the Future report, and you can see them here. They are to examine current inequities in mental and physical health among First Nations, Inuit, and Métis peoples, to consider the social, political, and historical contexts that have been the fundamental drivers of inequities of our health and well-being, to understand how reestablishing Indigenous peoples' health systems and ways of knowing and being are vital to addressing these inequities, and to explore practical strategies for achieving our health equity. And just a reminder for those who may be interested, June 20th is the 4th in this series, webinar series, and it focuses on environmental and mental health. So just if you want to put that in your calendar. So let's get to the order of business here. Today's presenters are Mr. Nathan Obed, President, Inuit Tapiriit Kanatami, Ms. Cassidy Caron, President, Métis National Council, and Vice Chief David Pratt, Federation of Sovereign Indigenous Nations, co-chair of the Chiefs Health Committee for the Assembly of First Nations. The speakers will be presenting an overview of the current realities for those that they serve, for their populations, and how that reality could change or should change, and perhaps making some recommendations of how we can get to that change working together. So as I said, we have three presenters. Each presenter is going to speak for approximately 15 minutes. We will hold all of the Q&A questions to the end after all three speakers have spoken. And you can put those, if your question says you listen to the speakers, into the Q&A, and then we'll go back to those for the discussion at the end. Our first speaker today is Mr. Nathan Obed, President of Inuit Tapiriit Kanatami. President Obed is originally from Nain, the northernmost community in Laber's Nunavut region, and now lives in Ottawa. For 10 years, he lived in Iqaluit, Nunavut, and worked as the Director of Social and Cultural Development for Nunavut Incorporated, so NTI. He has devoted his career to working with Inuit representational organizations to improve the well-being of Inuit in Canada. Welcome, Nathan, over to you.
Thanks so much, Dr. Greenwood. It's good to see you, and also just great to be able to be a part of this conversation here today. Also wanted to say hello to all those on the Zoom webinar and also my colleagues who will be presenting here as well today. I'll get right into it. I'm not sure if is there going to be a PowerPoint deck with this, or am I speaking to the points I'm raising?
If you have a PowerPoint presentation that you'd like to send me, President Obed, I can share it for you.
Okay. I apologize for this. There is a PowerPoint presentation associated with my speech, and Deb Van Dyke would be the one that would be sending that to you. She's on the call here, so I'm sure that she'll send it right away.
I'll keep an eye out in my email.
Yeah. In the meantime, I'll just get started. As I've been introduced, my name is Nathan Obed. I'm the president of Inuit Tapiriit Kanatami. There are approximately 65,000 Inuit in Canada, and we live in southern centers like Winnipeg and Edmonton and Ottawa and Montreal and St. John's, but primarily Inuit reside in Inuit Nunangat, which is our traditional homeland. Inuit Nunangat encompasses 2/3 of Canada's landmass. I'm sorry, encompasses 1/3 of Canada's landmass and over 2/3 of Canada's coastline. So although we live in small communities, 51 communities across Inuit Nunangat, we have a much larger presence when it comes to the geographic space in which we occupy, and then also from a rights-based perspective and an Indigenous governance perspective, we sit alongside the Government of Canada and provinces and territories with our own governance model, with our own treaties, and we have modern treaties or land claim agreements that have been signed between each one of our 4 regions and the Crown. So in our governance model, those 4 leaders of those 4 regions sit on ITK's board and direct our work. So when you're hearing about the work that we do, it is a reflection on the decisions that Inuit have made on the priorities that we have and the work that we as the national organization do. We have, as a population, some very stark differences in outcomes from most Canadians. Our infant mortality rate is 3 times the national average, 12.3 per thousand versus 4.4 for all Canadians. Our food insecurity rates are upwards to 70%. In relation to 9% of other Canadians. Our overcrowding rates for housing are 52%, and again, under 10% for the rest of Canada. And our life expectancy is a full 10 years less at 72 years versus 82 years for other Canadians. These types of realities go hand in hand with some of the challenges that we face within public health. We have the highest rate of lung cancer that is for one specific population in the world. We also have a TB rate that is over 300 times the rate of Canadian-born non-Indigenous people. We also have some of the highest rates of hospital admission for lower respiratory tract infections in the world. And this is specific to our children. A lot of that comes from overcrowding. Also, some of the challenges for ventilation in homes and other environmental factors. These are the types of things that we as Inuit representational organizations work on with our communities. We also have underlying socioeconomic conditions that really impact the ability for Inuit to stay healthy. Our median income is 23,000 versus 92,000 for all Canadians. So that median income gap is massive. Our high school diploma rates are around 34%, and that's in relation to 86% for all Canadians. Thank you so much for sharing the slides. I appreciate that. It's great to see that repair in real time. Also, our challenges in relation to employment. We have much lower employment rates than other Canadians. So this sets the stage for the challenges that we have to overcome. Next slide, please. Our vision for the future is that Inuit are healthy, thriving, and prospering through unity and self-determination. So the work that we do at ITK is always governed by this particular lens. We want to work together. We want to repossess the spaces of self-determination within healthcare, within education, within economic development, and within community development. The foundations of our healthy future lie within legislative, policy, program, and service gaps. And we focus our work on highlighting those challenges and then providing prospective solutions for those challenges to the Government of Canada, to the academic community, and also to provinces and territories. The standard of living that most Canadians enjoy is often taken for granted, and in many cases, so there is a lack of awareness of inequity in the way in which public health is delivered across this country and the way in which broader health services are delivered across this country as well. Next slide, please. We also talk about self-determination within a healthy future for Inuit and public health. The things that we value within a service delivery lens within our communities might be very different than what provinces or territories or the federal government may see as being the most important. Care, of course, and access to care is a primary concern, but the way in which that care is delivered matters a great deal. And just think about language and Inuktitut, our language, and we want it to be spoken in every aspect of society, including public health services. And the ability for Inuit to be provided services in Inuktitut is a key part of self-determination. Also, the decision-making that Inuit have in relation to the way in which funds are distributed, the way in which programs and services are imagined and then delivered. The ability for Inuit to participate in those scenarios and to partner as Inuit see fit is a key part of unlocking the best practices that can then change our socioeconomic status from where it is today to where we would like it to be moving forward. To that end, we've worked quite a bit on eliminating tuberculosis. We have partnered with the federal government to end tuberculosis in Inuit communities by 2030. This was a focus of the last 4 years now of our relationship with the federal government. We have a TB reduction goal of 50% by 2025 and total elimination by 2030. This is something that the government of Canada has never done before, which is to have ambition to end a public health gap in outcomes between Inuit and non-Inuit in this country. We hope that this can become a model for the way in which the federal government articulates ambition moving forward and how it then partners with Inuit or other Indigenous peoples in ending some of these socioeconomic gaps. We have done a lot of work to create regional tuberculosis action plans. We also have secured funding for some of this work, but we know that much more funding is necessary in the coming years to do the types of things that are necessary to eliminate TB. I know that people on this webinar would immediately think about housing, would always think about food insecurity and poverty reduction. And yes, those are key elements of our particular plan. Those are some of the driving factors that are not necessarily health systems based. We also recognize the need to mobilize in a public health way for outreach, to identify latent and active TB, to be able to treat active TB in real time when somebody contracts active TB, and to be able to do targeted community screenings and also understand TB in a much deeper way through research on how it affects Inuit in communities. So this is just an example of the type of things that we want to do in partnership with the Government of Canada and with provinces and territories, and also with the research community. It also shows what is possible with ambition, and I think we have a lot to be proud of in the work to date, although there is so much more work that we need to do to reach our goal by 2030. Expressing a goal is part of the process, though, and having clear ambition and saying that we want to do things together is, I think, a very important part of the relationship that we want to have with Canada moving forward. We want to get to equity across the public health sphere and we want to ensure that Inuit have just as much of an opportunity to lead healthy lives and to be supported in living those lives as any other Canadian. And we will still strive for that in all the work that we do moving forward. Thanks for the opportunity. I do have to leave around 10 to 2, so apologies in advance for leaving early, and Deb Van Dyke will be able to answer questions on my behalf in the Q&A session.
Thank you so much, Nitam, for taking the time. I know how busy you are for just being here with us today, and thank you for your presentation. It always reminds us of the work and support that we need to do in ensuring our health and well-being. I would like to remind participants, if you have any questions for President Obed, please put them in the Q&A so that we can get to those a little bit later this morning. So hi, Nita. I'm going to turn now to our next speaker, and that is Cassidy Caron, the president of the Métis National Council. President Caron is a Métis woman with roots in the historic Métis communities of Batoche and St. Louis, Saskatchewan. President Caron is the first elected woman to hold the office of president of the Métis National Council. As an entrepreneur, President Caron has advised and evaluated both provincially and nationally administered programs that aim to serve and support Indigenous peoples and communities across Canada. She has also supported the implementation of initiatives in, by, and for Indigenous communities throughout Canada in a variety of sectors, all of which sought to achieve an overarching goal of restoring balance and wellness to Indigenous communities. Welcome, and I have to say, I think I was saying your name wrong. I think it's Karen, and I was pronouncing it wrong. Oh my goodness. My apologies if that's indeed the case. So over to you and welcome, and thank you so much for taking the time to be here.
Great, thank you so much, Margot. Tanse Kioao, hello everyone. Before I begin, I'd like to acknowledge that I am calling in today from Williams Treaty Territory in Huntsville, Ontario. As Margot said, my name is Cassidy Caron, and you can pronounce it any. Some people have a French accent to it, and some don't. My family comes from St. Louis and Batoche, Saskatchewan, and I'm just really appreciative of the opportunity to speak to you all today. So thank you, Margot, and to the National Collaborating Center for Indigenous Health for inviting me to this important webinar. For those of you who might not know, the Métis Nation is a distinct Indigenous people that emerged in the early 1800s in the historic Northwest with a shared history, language, culture, and collective consciousness. And today, the Métis National Council is comprised of the democratically elected Métis governments, such as Métis Nation of Ontario, the Métis Nation Saskatchewan, Métis Nation Alberta, and Métis Nation British Columbia. And collectively, these Métis governments come together to mandate the Métis National Council as a body to advocate for and represent the Métis Nation at the national and international levels. So today, the presentation that I have for you really builds on the Visioning the Future report and highlights the abundance of work that has really been done since the report's publication for the Métis National Council. Since that time, we've done a significant amount of work to really build out our vision for Métis Health, and we have a lot of work that's currently in the process of being reviewed and published, so stay tuned for that. We'll go to the next slide. So we at the Métis National Council, all levels of government, external partners, and organizations have been reaching out to us in the last few years, asking us for how the Métis Nation really defines health. And so this is the current Métis Nation definition of health, and it has come from a large number of Métis community engagements and discussions with the Métis National Council Health Technical Committee. Through large numbers of Métis community engagements and discussions, our citizens have provided the MNC Health Committee with the building blocks to really create this definition. And this definition builds upon the World Health Organization definition, but really incorporates a Métis worldview. Of note, the inclusion of spiritual, environmental, and cultural well-being, as well as individual and collective well-being now and for the future generations. Next slide. So out of these engagements that we've been doing with Métis citizens across the homeland, while we're in the process of building this vision for Métis Health, the principles of Métis Health were developed. And so these are three of the principles of Métis Health: self-determination, of course, Métis people value the ability to be self-determining in all aspects of life, to maintain independence and autonomy, including their ability to self-govern. And of course, this applies to our health. Self-determination in health for Métis people really means being active and in charge of one's life, being able to access and really partake in preventative programs and really live a healthy lifestyle. The principles also recognize that health is holistic and multifaceted. So Métis people hold a comprehensive and holistic understanding of health and well-being, which involves physical, mental, emotional, social, and spiritual well-being. And Métis health is place-based. So interpersonal relationships are critical to Métis health. So family and kinship, communities really are the backbone and to Métis health. And so relationships within the world around us, including the land, water, and air, history, culture, cultural continuity, language, and identity are all interrelated and equally important in our health. And of course, that comes from land, that comes from our place. And so a holistic approach that does not silo physical health from these our other determinants are critical and necessary to our health. Next slide. All right, so you know, it's important in the work that we do when we talk about health for the Métis Nation to always note that Métis people don't have poor health outcomes because we are simply Métis. Poor health outcomes are a result of decades of oppressive policies that have effectively sought to erase or assimilate Métis people and the Métis Nation as a whole. The results of colonization has led to really a lack of understanding, a lack of awareness of who Métis people are, and that also leads to a lack of distinctions-based data, poor health outcomes, and higher rates of chronic disease. So these inequities cannot be understood in isolation from colonization, forced assimilation, and social exclusion. And to overcome this reality will require a Métis-specific approach to address these issues, which has resulted in the development and the discussion of Métis social determinants of health, which is on the next slide. So the Métis social determinants of health approach seeks to acknowledge and understand the root causes of a variety of historical, economic, social, and political inequities. And it is a departure from a variety of historical, economic, social, and political inequities. It's also a departure from a siloed biomedical model or ideas that emphasize stereotyping by suggesting that the health inequities faced by Métis people are a matter of genetics or individual or community choice. The Métis social determinants of health illuminate ways in which social, cultural, and economic marginalization impacts health. And the Métis social determinants of health links history, policies, and practices that have contributed to separate rates or poor health outcomes and assists in setting out a path forward to improve health and well-being. So listed in the social determinants of health for Métis here, of course, is colonialism, as well as childhood experiences, as well as the ability or lack of ability to grow up within Métis culture. And all of these pieces contribute to Métis health. Next slide. So this model was developed by the Métis Nation of Alberta, one of our governing members, and it was also developed through community engagement in Alberta. And it's now a part of our national model. So it was validated by members of the Métis Nation Health Committee for use more broadly, as the high-level themes are collective, while the approaches to achieving those priorities may be different within each respective governing member or community. We obviously use this model as it's an infinity, and so there's no starting point in this graphic, and all priorities identified by Métis community members across the Métis Nation homeland. It's meant to intersect and flow into different solutions. We'll go to the next slide. So the lived experience and community voice of Métis people must be valued, grounded in community engagement, which centers Métis experiences, perceptions, and needs. For those reasons, it is important to note the following 13 priorities were developed through, once again, robust community engagement with each of our governing members, flexibility and engagement styles and questions that were asked allowed for each gathering to talk about these priorities in really meaningful ways. And all of these priorities are currently in different states of development. The MNC and our governing members are involved in achieving these priorities with a variety of government and organizational partners. However, there is always a call to action for those of you watching this presentation. The Métis Nation, the Métis National Council always values authentic and meaningful participation and partnership to achieve these goals. So this is just a call to all of you to never hesitate to reach out to any of the governing members within the Métis National Council. So again, Métis Nation British Columbia, Métis Nation Alberta, Métis Nation Saskatchewan, or Métis Nation Alberta, if you think that there's an opportunity to contribute to addressing these priorities. And it's also should be noted that these priorities are grounded in the Métis social determinants of health previously explored on the last slide. I'll go over these just really briefly to give a little bit of an introduction to each of these priorities. Oh, we'll just keep it on that last slide there. So the most heard priority that I always hear as president of the Métis National Council is around health benefits for Métis citizens in all our jurisdictions, which would give them access to coverage for services that are not covered through social programs, private plans, and provincial and territorial health insurance. Health benefits remains outstanding as a fiduciary obligation from the federal government. And we still face significant gaps in things like medical transportation and accommodation. And that continues to contribute to impacting the ability of Métis people to access appropriate medical and well-being supports. Community-based long-term care and palliative or hospice care. Our vision for health includes increased access to long-term care services for elderly Métis and Métis living with disabilities and or chronic conditions, as well as increased access to respite care, palliative care, and chronic illness support and prevention, including, like I say, travel supports. Another one of our priorities is building meaningful collaborative relationships. Like I say, we are constantly building collaborative working relationships with the federal and provincial jurisdictions, as well as First Nations and post-secondary institutions to co-develop a range of complementary and integrated services and supports to address Métis health needs and service gaps, as well as facilitate service delivery. Comprehensive community health centers. We've had this conversation quite largely with a lot of our citizens. Our vision for health includes a series of multifunctional, family-centered, Métis comprehensive community health centers that bring health services and supports directly to our citizens in our communities. Increased Métis health human resources. It's also our hope to train healthcare professionals and community development workers to deliver culturally safe services. Offer specific training for Métis and Indigenous healthcare workers that recognize the unique situation of Indigenous peoples. We will also be developing educational strategies for healthy living, disease, and accident prevention, promoting those existing health-related services that are available to our Métis citizens. Also, our vision for health includes strengthening the existing Métis cultural and community-based supports, including multi-generational support, support for women and girls, and as well as the broader community. By enhancing existing telehealth and related online platforms to increase access, enhance health service delivery, and improve continuity for Métis, especially in the rural areas, we do hope to expand virtual health opportunities. Métis research and needs assessment and evaluation, that's a huge priority for the Métis Nation because there is a lack of distinctions-based data currently. So one of our priorities is always to continue to seek adequate funding and support for ongoing Métis government-led health research and needs assessment, as well as funding for evaluating Métis health programs and service delivery. Building culturally competent health systems through the development of programs and curricula to train healthcare professionals in the health system to understand the unique health issues experienced by Métis people, as well as developing culturally appropriate services that Métis can access without discrimination or declining care quality. Our vision for health also includes providing adequate mental or maternal health services to Métis communities in rural areas, as well as culturally sensitive healthcare services, including Métis community-led maternity care. And finally, culturally relevant sexual health and reproductive care. Our vision for health includes improving the availability and accessibility of Métis community level data on sexual and reproductive health outcomes, and investing in culturally safe education initiatives developed and led by our Métis governments and communities to facilitate access to ongoing sexual health and reproductive care and support. So I know that's a lot, but those are the priorities that have emerged through our engagements in the last year. We'll go to the next slide, which is our national vision for Métis health. So through Métis self-determined healthcare systems, Métis people are healthy, happy, resilient, grounded in their cultures and languages, and thriving as individuals and members of their Métis families and communities. And go to the next slide. So these are some of the recommendations that we have to implementing our vision. So it's important to recognize that self-determination over health requires the appropriate investments in the areas of financial support, system level legislation, and changes. So the incorporation of regional specific priorities and models ensures that the programs and services developed are meeting the diverse needs of our communities and that are served by each of our governing members. We also recognize, of course, that there is long-standing inequities in Métis data, and in order to achieve our vision of health, the appropriate information sharing agreements that allow Métis sovereignty over data have to exist to support our governing members' capacity to collect, analyze, use Métis data to support their communities. So, and then the last slide is just a thank you. I know that's a lot of information to throw out there at once. And again, our Métis vision for healthcare is a document that is currently being reviewed, and it will be public very soon. But thank you for listening, and happy to answer any questions at the end of the presentations.
Thank you so much, Cassidy, for what an informative presentation. Thank you for taking the time. I know how busy you are, for being with us and sharing this information. Our final speaker is Vice Chief David Pratt. Now, I think it says a different name under on your screen, so I hope I got it right.
That's my EA's name, Myrtle Morin.
So I won't call you that.
I'm not Myrtle. Well, you can call me Myrtle if you want. It's actually Vice Chief Pratt. I don't know why her name's up there.
Okay. But thank you for taking the time to be here with us. I know how leadership is so busy. I just am grateful to everyone and to you for being here. I just have a short bio. So Vice Chief David Pratt is a member of the Musqueam. Thank you. Musqueam Soto First Nation, located in the unceded traditional and ancestral lands in Treaty 6 territory. Vice Chief Pratt knows and understands the importance of maintaining close ties to family, community, culture, and connections to the land. Vice Chief Pratt is currently in his second term as executive member for the Federation of Sovereign Indigenous Nations, FSIN. He is an advocate of lifelong learning, combining traditional and Western knowledge, and strongly believes that revitalizing language is a pathway to strengthening community connection. Learning from the past to right the wrongs. Vice Chief David Pratt is an eloquent speaker and can often be heard championing alongside the FSIN executive for the implementation of UNDRIP, TRC's calls to action, and the missing and murdered Indigenous women and girls calls to justice. Welcome, Chief Pratt. Over to you.
Well, good morning. Thank you for having me, and it's good to be on the presentation this morning with all of yous. And I trust you have the PowerPoint there. I think it's been sent to you by the AFN. Andrew has forwarded to you, I trust. And
Hi, Vice Chief Pratt. I don't have a PowerPoint for you, I'm afraid.
oh my goodness. Okay, I'm just give me 1 second here.
Sure.
What's your just give me 1 second here.
Sure.
I'm just texting Andrew here.
I'm sorry, Vice Chief Pratt. Jonathan Dunn sent it on to Donna, so she should have gotten it. Yeah.
Donna, you want to check your spam email?
Jonathan's emails never go to my spam.
Okay.
Yeah, I don't have anything yet.
Myrtle, can you get on it right away, please? Get them to
Yeah.
forward it ASAP.
I will call Jonathan again. Thank you.
There we go. I got it. Here we go.
Okay. All right. Thank you. We got it. Anyways, good morning, everybody. It's good to be on the presentation this morning. First of all, I want to acknowledge the beautiful Treaty 6 territory. I'm calling from here in Saskatoon. It is allergy season right now, and I think it's one of the worst seasons. So that's probably why my voice sounds a little hoarse. My God, the pollen is crazy right now. I don't know. This seems to be like one of the worst years we've had for allergies, and the Claritin and stuff ain't helping. But it's good to be here with you this morning. And I do want to acknowledge the beautiful unceded, unsurrendered Treaty 6 territory that we're calling from on this morning here in Saskatoon. I do also want to acknowledge our colleagues, President Obed and President Karan from the Inuit and from the Métis. It's so good to hear you and see you this morning virtually. I'm looking forward to the day when we can all gather in person. We just finished a couple of days here with Cindy Blackstock on the agreement in principle, and we had a couple awesome days of information as well as Don Bernstick. So we've been dealing with that, but I'm ready to get started on the presentation. So if you want to throw it up on the screen, I'm ready to go when you are.
Okay. How did that work?
Okay. All right. Well, we're happy to see you all this morning, and I'm happy to be able to do this presentation to the 7 Generations Continuum of Care, exploring the realities and potentials in First Nations wellness. Next slide, please. All right. The objective of this presentation is to summarize the context of the current healthcare landscape, provide the background of the 7 Generations Continuum of Care resolution, and characterize a working definition of the Continuum of Care approach. So that's what we're aiming to accomplish with this presentation. We'll go to the next slide, please. I want to start and share just a glimmer of the natural continuum of care that existed before the arrival of those living beyond the oceans. A word to describe this time would be balanced. Everything had their place. Nature and every member had roles and responsibilities, and everything was unique in that uniqueness, that there was unity that formed our societies. Nature, the elements, animals, and our plants and medicines took care of us. And the protection and connection to the earth enabled us to be caretakers of our families, the young and old, our communities, and the reciprocal relationship and the complete holistic arrangement. Our society's wellness, a continuum of care, was and always been circular in structure. It was prevention-oriented, proactive, solutions-based, and secure from pre-birth to death. It supported everyone and everything towards health and wellness. Balance was observed and practiced by each extension of creation, externally and internally. Next slide, please. However, through the process of colonization, the balance was offset, and First Nation ways of being were radically changed by mechanisms of division, and fragmentation. There was a clear foreign mandate to engage and assimilate through the process of breaking down and carving out that had affected our culture and well-being. Our lands, our language, culture, medicine's knowledge have all been methodically dissected, removed, and given to museums, collectors, the medical fields, and various governments. Their efforts to remove us from our identity and ways were their premeditated method of trying to weaken us and assimilate us. Next slide, please. Despite the ruptures caused by the process of colonization, we remain today a resilient people, but we have been given a fragmented medical system that is filled with gaps, loops, and hurdles that we don't even view the hospital the same way a general Canadian would. Typical Canadians would associate the hospital waiting room with a little discomfort, maybe anticipating the outcome of their appointment, but generally having confidence the healthcare system will coordinate a follow-up and provide reasonable next steps. But for many First Nations people, we have a different view. We have seen something that would be represented as a collapsed bridge, where the owner of the bridge tells us there's still a bridge there. Last year's budget was spent millions of dollars for upkeep. And when we ask the owner of the bridge, can we help to repair the bridge? We get a quick no. We ask them, can we build our own bridge? The owner replies, no. So then we say, you know, it's probably better if we just cross the river another way. And we're told, no, if you want to get to the other side of the river, you have to use the bridge. Next slide, please. Taking the bridge illustration, we can see our current landscape is riddled with cracks and holes. We have a complex multi-jurisdictional environment that involves different levels of care, different sources of funding, different healthcare workers, and management and delivery models. The care is fragmented, racist at times, and siloed, that communications are vulnerable to breakdown. The difficulty of navigating through the system is a struggle, and the quality of care is not guaranteed. Then, if the required level of care is not localized, First Nation members have to go through a different structure of the medical system off reserve or simply go without. The numbers of barriers in care is unacceptable, and the hesitancy of seeking care due to those issues is a common compounding negative effect that causes more harm to the individual and community. So there are changes that need to happen. We need to have a culturally grounded focus when it comes to the delivery of healthcare services to First Nations people in this country. Next slide, please. A focus to transform the system is to a First Nations way. The current system has alienated itself from its original structure of patient-oriented care, and it's more of an industrial assembly line. They limit for each patient to see the doctor so they can see the next person as quickly as possible. As we see from the first half of this table, from an assembly line, we need to transform to an all relations standard so that we focus on the individual, family, and community. We need to leave the sickness-based model and turn towards a wellness promotion model. We even need to change our language and limit our use of the term patient and use the term client. Because with the sickness-based model, the term patient is now associated with sickness. But with a wellness promotion model, a client will not assume the individual is sick. This could be just visiting his or her healthcare provider for a checkup, and that's it. The term client also empowers the individual to be an active participant in their own care plan. And visiting each point of the list with the multi-jurisdictional issues, we would replace it with a First Nations-led system. From a Western-based modality of health, we would transform it to a culturally anchored care that applies the two-eyed seeing approach, bringing the two worlds inclusive of all knowledge and practices. The siloed health services, we need to have better coordinated partnerships. Examining the health services staff, we need to respect the physician, to be inclusive of other healthcare providers. We need to change the pharmacology industry complex and promote our own Indigenous healing practices. And we need to build up the number of First Nations in our healthcare provider positions and advocate for community helpers to receive funding, accreditation to better support our staff and communities. Next slide, please. In order to ensure these transformations, the federal government needs to meet with us on the three main criteria. In 2017, AFN released the First Nations Health Transformation Agenda. and it was a foundational report with numerous recommendations to transform health systems for First Nations, but its main three overarching goals to self-determination, health governance, and service delivery were getting the relationship right, such as removing jurisdictional ambiguities and ensuring that all collaborative or co-developed initiatives. First Nations are equal partners from the very beginning. 2, First Nations capacity. First, there needs to be support for community-based workforces to reduce high human resource turnover rates. This includes equitable pay, access to professional development, accreditation, and access to technologies, as well as ensuring support for data capacity and sovereignty. 3, sustainable investments. There needs to be predictable and sustained funding envelopes to meet needs proactively and with flexibility, with reduced reporting requirements that restrict holistic solutions. Next slide, please. And meeting the momentum with the recent royal assent of the Bill C-15, the United Nations Declaration on the Rights of Indigenous Peoples, stating that Indigenous peoples have the right to determine and develop health, housing, and economic and social programs affecting them through their own institutions. AFN Resolution 19/2019, entitled Developing a 7 Generations Continuum of Care for First Nations by First Nations of Health, Economic, and Social Services. This is where it was put on paper that we need to develop a holistic continuum approach of supports and services to address long-standing and growing gaps for continuing care in First Nations communities and to ensure health, social, and economic well-being for First Nations as they age and as their care needs change. Next slide, please. So a 7 generations continuum of care approach to wellness is the vision for health and well-being that is grounded in First Nations way of knowing. Next slide, please. We're almost finished, but let's break the title. 7 Generations Continuum of Care members of the AF team who drafted Resolution 19/2019 wanted to make sure that we had at the forefront the 7 generations principle included, so that in the development of this approach, there was a driven intent to make sure every decision makes a sustainable world for our unborn. That's why the process should not be rushed. It needs to be as inclusive as possible to make sure no one is left behind and make sure the system is malleable and scalable so that when our communities grow, the infrastructure, human resources, and funding can grow as well. And the continuum of care can be detailed as a continuous, dynamic, holistic approach that provides targeted care to the individual group's needs over a lifetime. It must be effective and encapsulate prevention, intervention, and post-vention strategies to serve its population. Next slide, please. Our current working definition of 7 generations continuum of care is a holistic model in which it is accessible across all dimensions, built around the individual and community, governed by First Nations collaboratively, and integrated into the broader healthcare system that ensures health, social, and economic well-being, culturally safe, embeds traditional medicine as an integral aspect of care, maintainable and sustainable for the future generation, and has the data and information needed to effectively manage and evaluate services. Next slide, please. Understanding a continuum of care definition is ever evolving, and we will look different between regions and nations. We drafted this definition for the 2020 report, Options for a First Nation 7 Generations Continuum of Care. It was a literature review that provided context on supportive legislative environment, existing frameworks, and recommendations of commissions regarding Indigenous health care, and reviewed 4 case studies of governance management and health services of integration. As great as this overview report was, building a foundation and context of the subject, we are looking to expand upon a few topics. We'll need more insight of the accessibility and disability topic, a broader intersectional lens of the other diverse populations, an expansion on the economic development and infrastructure connection to health, and an enlargement of the small community and urban First Nations lens. Despite this, it was an excellent starting point. Next slide, please. No doubt there will be different interpretations and applications to a 7th generations continuum of care, but there will be common encompassing themes. It will be sustainable and scalable. It will exercise self-determination and sovereignty over the health system. It will be integrated and coordinated care. It will be holistic in the health and social health system that includes Indigenous healing practices and culture. It will increase the number of First Nations healthcare providers. It will achieve substantive equity in both access of health services and outcomes of health intervention. And it will be a targeted approach to addressing the myriad social determinants of health. Next slide, please. So the 7 generations continuum care is a process. Some First Nations already have healthcare systems in place, and some nations are in the midst of setting up their own workforces and regional authorities. So we're all in different stages, but we're all on a similar path. As an elder said a few weeks ago at a Vatican press briefing, we are on the railroad track. If you're by yourself, it's hard to balance on the metal beam. But if you're clasped hands with someone balancing on the parallel beam, you can restore balance and look forward. In our track, it seems that we have to drag our partner nation, Canada, on that reconciliation journey. We need to show that reclaiming and restoring is the only way forward. And I would like to conclude the presentation with AFN's response statement to the Chief Medical Officers of Canada's Public Health 2021 report. We stated that First Nation systems follow a natural continuum of care that is based on the cycle of life from pre-pregnancy to death, that weaves in our medicines and teachings. While there is no singular definition of First Nations wellness, there is a shared understanding of the interconnectedness between the physical, mental, emotional, and spiritual realms, and the understanding that these are shaped by the environment in which we live. Next slide, please. So miigwech, thank you all for listening to the presentation on behalf of the Assembly of First Nations. And now I'll try our best to answer any questions you might have. Thank you.
Thank you very much, Chief Pratt, for that really informative presentation. What we've done is I've encouraged all of you who are on the webinar today to put your questions in the Q&A part of the webinar. And so we are going to now go to that portion of the webinar where we can now have some questions and some dialogue and interactions. So Donna has been watching the Q&A and sorting through the questions. So I'm going to ask Donna now to sort of facilitate this part of the portion of the webinar. Over to you, Donna.
Absolutely. Thanks, Margot. And just a reminder to participants, you can actually vote questions. If you see a question there that you like, it'll jump to the top of the queue. So my first question is for ITK, and I believe we still have Deborah Van Dyke on the line. Deborah, are you there? Maybe not. Oh, I don't know that she is. Okay, we're going to drop down here then. So we have someone wondering about how, this is a really long question. As Indigenous groups in Canada that share similar and same determinants of health and unfortunate health inequalities, how can we engage all levels of government in these health priorities instead of often this is a federal issue or their own issue conversation? So in order to address the many Indigenous families who live in rural and urban centers, for example. And maybe President Caron, we could start with you.
Sure. So that's a great question. I'm trying to find it here so that I can continue reading it at the same time. I mean, for us, it really does come down to building collaborative partnerships, of course, with the federal government, but also with provincial governments, as well as the organizations that exist within communities where Métis people largely are today. You know, it is our hope one day to eventually create Métis community health hubs in our communities so that we can integrate all of the different programs and services coming from the federal government, the provincial government, our Métis governments, any of the programs that they're specifically delivering for those communities, and really bring them all together. So for us, I think the answer to that is just simply by building respectful and collaborative partnerships.
Great, thank you. So maybe over to you, Vice Chief Pratt. And the question again is just, how do we engage all levels of government in these healthcare priorities that you've all spoken to?
Thank you. Well, I think the main thing is for us to be at the tables when the Minister of Health and Minister of Indigenous Services Canada are meeting with the Ministry of Health and the Saskatchewan Health Authority. Of course, I can only speak pretty much for our region. And sometimes there can be challenges. There's always that jurisdictional fight, right? Constitutionally, the provinces do have the are given the healthcare mandate to deliver healthcare services for their citizens. But for First Nations, they're under the new treaties and the old treaties, Canada and the Crown has a fiduciary obligation to provide those services to our members. So right now, this health transformation is an important piece because right now there's important gaps in services and programs, and particularly the level of racism we face here on the Prairie provinces. We're all familiar with the Joyce Echaquan case that happened last year, an Inuit lady that that was kind of the spearhead for addressing racism in Saskatchewan and led to the establishment of the First Nations Health Ombudsperson here in Saskatchewan, which we're currently working on setting up and getting going. That office will be working to address those gaps in services and work with the Saskatchewan Health Authority. So I think the important thing for us is to be at the tables. I think that when Canada and the provinces, our territories, are having those conversations, we need to be in those rooms. The days of, I can't believe it still happens, but if you can't believe it, in 2022, the days of Canada and the little brothers of the provinces and territories meeting in a room by themselves and deciding our future are over. First Nations and Indigenous people want to be involved in the decisions, whether it comes to the delivery of healthcare services and the Treaty Right to Health and the Medicine Chest Clause of Treaty 6, or whether it's education and justice and so on and so forth, our lands and resources. So I think it's important we be sitting at those tables. And I think that anybody that has influence with government or knows MLAs or MPs or ministers, it's important that you carry that message forward, that we have to be at the tables. And it's important, if we're going to get it right, we have to be a part of the decisions that are being made. Thank you.
Thank you, Vice Chief Pratt. Deborah, could we hear from you on this question? It's how do we engage all levels of government in the health priorities that we were presented today?
Yeah, my apologies. I certainly can't answer these questions as well as President Obed could, but he had to move on. And I think, so yeah, it's definitely to echo what both Chief Pratt and President Carroll brought forward. And I think from the Inuit perspective, one of the major pieces of work that's been done recently is looking at the Inuit Nunagat policy space. So engaging across government with that single focus on the Inuit Nunagat policy space, to be able to engage with government as kind of as one entity or two nations engaging with each other, as opposed to kind of engaging kind of right now it's very piecemeal. We engage with each sort of part of government and each level of government independently, as opposed to engaging across the whole. So a lot of work there being done to engage across that single policy space.
Great, thank you. So I have another question for everyone here. I have a participant who's concerned about the lack of distinctions-based Indigenous health data. So will this be improved through the distinctions-based Indigenous health legislation currently being promised by the federal government to be developed with health leaders? And how does distinctions-based Indigenous legislation relate to your presentations?
So I can definitely go.
We could start with you, President Karen. Thank you.
Sure. So for the health legislation, the distinctions-based health legislation, that's really what has driven all of this engagement that I presented on in the last year or so. The vision for Métis Health document that our governments are putting together, and when I say our governments, I mean our Métis governments, are really establishing. The health legislation is really driving that work because we want to be ready. We want to know our priorities. We want to know what our citizens want when we do get to the table to co-develop that health, the distinctions-based health legislation. Distinctions-based data for Métis people is so critically important. There's such a lack of distinctions-based Métis data, especially within health. We have a number of Métis health researchers who are doing some incredible work right now, who are starting to really highlight that the lack of data right now for Métis. But I think that we really do need to make sure that we are taking that into consideration when we are co-developing that legislation. I think that without knowing, the baseline data of Métis health across the Métis Nation homeland, we won't know if it's improving with that legislation. So it certainly will need to be built into that.
Thank you. Vice Chief Pratt, can we go to you for this?
Could you repeat the question? I'm sorry.
It's just a question around, there's general concern for the lack of distinctions-based Indigenous health data. And, do you think that might change with the new legislation being introduced by the federal government?
I think it might, but right now there is some work going on at AFN as well as FSIN here regionally, and I'm sure it's happening in the other regions, developing data centers. And already the FSIN does store the regional health surveys for First Nations. And of course, we operate under the OCAP principles that data is sovereign to each of our member First Nations. And we only share it with their permission. It's not that we don't, we're very mindful that we have to respect each of our member nations' sovereignty when it comes to the storage of that data. But we are working on a regional data storage facility. We know that data is so important. We have been in some early discussions with working some of the post-secondary institutions here within Saskatchewan, and I'm sure that those conversations are happening in the other regions as well in terms of more research from our post-secondary institutions when it comes to that. We know that data is so important because it's key and it's critical to be able to guide government in their decision making and their policies, as well as going to Treasury Board for those investments that are sorely needed at the community level. In regards to the distinctions-based health legislation, I was very happy that the government of Canada put it off for a couple of years to do more consultations, because I know here regionally there's some concerns we have in Saskatchewan, and I'm sure some of the other regions just too as well. We want to get it right, and as President Caron said, we want to make sure that it's true co-development. A lot of times Canada says co-development, it's their key word, and not to bash Canada, but sometimes their co-development process is we're going to take all the engagement, put it into a report, give it to our lawyers, put our lawyers in one room, and they'll draft the legislation. And then if we have a concern about a line or two, your lawyer will be outside waiting in the next room from AFN, and then they'll come in and they'll make an edit if they feel like it needs to be edited. And then they kind of exclude us from that. So I think true co-development would be us working hand in hand with the Canadian government to help develop that legislation to make sure they get it right. Because the last thing we need is to be set up for failure and to take over a system that's already failing us as Indigenous people. What we'd like to do is we want to have the best quality of care and the #1 healthcare service in the entire world as the first peoples of this land. And too long we've suffered, and the data is there to show the challenges that we continue to face as Indigenous people. So I hope that answers the question.
Absolutely, thank you. And Deborah, could we go to you? Just a comment on the importance of distinctions-based data, or the lack thereof, and if that might be improved with the new legislation.
Yeah, absolutely. And certainly the same issues in terms of being able to, the availability, the collection, and the availability of Inuit specific public health data is certainly an area that's very challenging, and the pandemic really brought that to the forefront as well, in terms of being able to know what is happening in Inuit regions and in urban centers in relation to Inuit, and really understanding the issues to be able to advocate for them and address that going forward. And certainly, one of the challenges that hopefully would be part of the health legislation is that in Canada we do have a very we have 13 different jurisdictions collecting different data in different ways. And Inuit live across a number of those jurisdictions. And so And a lot of that data comes from kind of the province and territorial levels. So being able to influence some of the policies and legislation and that kind of thing around sharing of data across jurisdictional lines and being able to access that data and recognize who the true owners of health data are, which are the Inuit, are the true owners of their data, not kind of governments or health systems and that kind of thing, and how we can work to ensure that the true owners of data are the ones that are able to access it and use it to be able to move forward in their vision for public health in the future.
Great, thank you. So I have another question here that maybe we would actually start with you, Deborah. It's how important are all-weather roads for food security, health access, and health outcomes? And is there any research related to those kinds of roads and health that you're aware of? Oh, you're muted.
My apologies. That might be more of a question for Chief Pratt, actually. With the exception of 2 communities, so 49 out of 51 Inuit communities are fly-in communities only. So there is work being done in some communities around access around all-weather roads. I'm not aware of research specific to health or food security in relation to that specific to Inuit, but I believe it's likely more, there might be more to say on that as that's an issue maybe more relevant on the First Nations side of things.
I'll gladly speak to that. Yes. Can I go ahead?
Oh, yes, please.
Madam
Yeah.
Chair, thank you, Mark. Thank you. Yeah, definitely it does. There is a correlation between remoteness. We actually, it's right. I'm learning more about this right now. We just recently, in regards to the agreement in principle on the child welfare settlement that they're currently negotiating with Canada, we established a table, the Northern Alliance of Remote Communities, with NAN, MKO in Manitoba, FSN here with our northern and remote communities, Treaty 8 chiefs in Alberta, and NWT. So there is a huge issue when it comes to costing, and of course food security is a big thing, because I'm sure you're all aware of the prices. It's ridiculous. It's like, a gallon of milk down here in Saskatoon is anywhere from $5 to $6. And up in our northern communities, that gallon of milk is double because of the freight. And even in the NWT, I've seen the prices where it's anywhere from $16 to $18 for a gallon of milk. Well, how can you, when you're in income assistance, and I'll give you another example, the challenges our people face is even the cost of hydro and power. Sometimes those hydro and power bills are $2,000 to $3,000 a month. Sometimes you have 18 to 22 people living in one home, and there's no roads into the community, and the cost of living, the cost of gas, the cost of lumber, the cost of everything has just gone up in these last few years. All of us are feeling it at the gas pumps right now. We're paying $8 a gallon of gas here in Saskatchewan. Who would have thought that day would come? I remember the day when they thought the world was ending when it got to 63 cents a liter. But there's lots of issues around that. I'm not sure about any data or studies. I think NAND is doing some work on that right now in terms of the costing, particularly specific to child welfare, and we're actually working on a framework for costing for remoteness and the challenges and for the northern and remote communities across the north here of Canada. But we're hoping to use that framework once it's done in child welfare to hit all the other issues in health, social, education and justice, and so on and so forth, to address some of the serious funding inequities that First Nations people continue to face, particularly in the north. The challenges are huge, and roads do have an impact. It does lessen the cost when those roads are built, but a lot of fly-in communities still exist in Canada. So there's lots of challenges that come with that. So I could go on all day about that, but I'll cut it short. Thank you.
Thank you. President Karen, I have a question just for you here. So why are Métis people not included in non-insured health benefits? And what can be done to change that if that's truly something that is needed?
Yeah, so that question definitely just goes back to history. And, Métis people, we've kind of just been in this jurisdictional hot potato between the federal government and provincial government, all the way up until 2016, when the Supreme Court case of Daniels came down and found that Métis people do fall under federal jurisdiction. And so up until then, it was kind of a back and forth between who has jurisdiction over taking care of health for Métis people. And so that's why we've just been excluded out of the health benefits FNIHB. Today, there's different ways of going about it. And there's different ways that we have these conversations with the federal government. The health distinctions-based health legislation is going to open the door into looking into how we can kind of achieve the objectives that we want from being involved, but it doesn't necessarily mean that we want to necessarily just jump right into FNIHB. We have to look at the self-determination and self-government, how we can actually deliver these services to our people ourselves through our Métis governments as we negotiate these pieces. And so it goes back through history. That's why we've been excluded from that. It's a constant conversation that we have throughout our communities, but a lot of different opportunities that we're exploring right now to be able to provide those services to our citizens.
Great, thank you. So I have a question for everyone here, actually. So what are some current issues for advancing public health and wellness transformation for some of your communities? So maybe Vice Chief Pratt, we could start with you.
The current issues?
Yeah, so I guess you could speak to challenges or opportunities in terms of transforming health in your communities.
Well, I think we've got there's always lots of opportunities, right? And I think I can only speak within the Saskatchewan region specifically, but also mention some of the work that's going on in British Columbia. The establishment of the BC Health Authority was huge for them, and they've done a lot of work now. A lot of that health transfer that Canada is currently undertaking in some of the other regions, Saskatchewan was ahead of that. Back in the 80s, we were already undertaking the health transfer. So right now, the biggest issue that we're having, even with non-insured health benefits, is that we want to make sure that as we're moving forward and as the transfer is being done by Canada with all the services and programs, that it's sustainable, because we have a booming population right now, First Nations people, particularly in Saskatchewan. I mean, we probably have a phenomenal growth rate, within Saskatchewan. Non-Indigenous people are having 1 or 2 children. Our kids are having ball teams, 7 to 9 kids. It's still happening, large families. So as our population's growing, the level of investments that Canada needs to make has to be significant. Right now, I think the health transfers are pegged at a 3% growth rate, while our populations are growing probably at 17 to 20% in some of our First Nations significantly. So we have to work on that as we're moving forward on transfer and on distinctions-based health legislation. We got to make sure that as Canada's turning over more of those service deliveries, including non-insured health benefits, which the discussions are happening right now, we have to make sure that it's number one, sustainable for our people. So I think there are a lot of opportunities. We just got to get it right. We don't want to take over we don't want to become the new NIHB and then we're denying people orthodontics, we're denying people eyewear, we're denying people, we're having to buy the cheap generic drugs and saying, well, try this drug first. If it doesn't work, we'll get you the good stuff that works. And that's what's happening right now with non-insured health benefits. So we want to make sure that as those programs are being transferred over, there is a lot of opportunity right now, but we got to get it right. And I do want to acknowledge Canada's commitment to improve the services and turn those over to First Nations people. But we just have to make sure that it's done with sustainability in mind. Thank you.
Thank you. Deborah, maybe we could just go to you now. Some of the biggest challenges and opportunities in terms of transforming health and wellness in Inuit communities.
It's a very big
question. I know.
But I think, looking specifically kind of at the public health side of things is one of the major challenges is that there are so many immediate issues and crises that that come up. You know, looking at kind of the example, say, of tuberculosis, where we have the immediate issues of outbreaks and cases in communities, and how do we support those communities and address those cases clinically, but we have a tendency to kind of get caught in that immediate need loop of kind of addressing clinical needs, addressing illness, the illness that's in front of us, addressing the sort of the short-term kind of infrastructure issues. There's, you know, the short-term staffing issues is another one, in terms of the, you know, being able to access healthcare workers, and, you know, being dependent on a high level of rotational healthcare providers coming from the South to really address those, the really immediate needs, and the, you know, and certainly the pandemic really showed that as well. And so one of the biggest challenges is, you know, with all of that focus and all of that energy that gets put into those immediate needs, the larger needs of public health and really addressing root causes around social determinants of health and that kind of thing really get pushed to the side for capacity reasons and for resource reasons. It's, you know, it's, and just the magnitude of some of those issues. So being able to kind of crack out of that cycle of addressing immediate and, you know, short-term and medium-term needs, and being able to look at that big public health picture from, you know, from the big perspective, and looking forward at the future of addressing some of those social determinants of health. One of the, you know, by far one of the largest is the housing issue, and being able to really invest strongly in that and bring together, you know, many layers of government and, at all levels and different departments, and really invest in the funding and the resources that are needed to really look at that, building up housing and infrastructure within Inuit communities would have a massive impact on public health going forward. So I think that yeah, being able, and, you know, we are seeing some movement in that area, and definitely some opportunities and a willingness of government to also recognize that they need to crack out of that immediate cycle. And certainly, you know, the amount of resources that were used during the pandemic to protect Inuit communities from the catastrophic effects or potential catastrophic effects of pandemic, because you know, of the fragility of some of these social determinants of health and the inequities of some of those social determinants of health, where we have to pour a massive amount of resources into the addressing the crisis, where really we, you know, in a future where there, you know, health equity is achieved, we wouldn't need to be pouring all those massive amounts of resources in just to avert kind of the crisis of the moment, because there, you know, that stability and you know, and vulnerability, or there's stability in the system, and the vulnerability to catastrophic impact would be much lessened. So that's,
thank you so much. Yeah, and President Karen, I'll leave you with the last word, and then we'll turn it over to Marco.
Great. So I mean, Deborah said it really well there. A huge challenge is definitely addressing the immediate needs, and of course, everybody knows how immediate many of these needs were in the last 2 years with the pandemic, and of course the opioid crisis in our communities as well. There's a lot of immediate needs that are kind of diverting attention away from transforming the system as a whole. Again, one of the biggest challenges that we seek is the lack of distinctions-based data for Métis health needs. And I saw a question in there as well about you know, Indigenous peoples who are currently incarcerated in the federal institutions and their healthcare issues. You know, we currently don't have any capacity or understanding of you know, the data, the distinctions-based data of our citizens who are incarcerated, and we are working on that, and that is linked right directly to our health, as well as environment and climate change. All of these pieces that are affecting our citizens' health, you know, there's so much that we have to break down the silos and start looking at these pieces as one, as a holistic, with a holistic lens. And I think that's an opportunity that presents itself right there. There's a lot of work taking place right now through collaboration with the Métis National Council and our governing members, which will start looking at these pieces, looking at the impact of in the environment and climate change on our citizens' health, and starting to identify the different ways that we can start getting this distinction-based data, and finding the different ways that we can have information sharing agreements. I think just through these conversations, these webinars, growing people's understanding, education, and awareness, those are definitely all stepping stones to transforming health systems. And I just, again, I'm just so grateful for the opportunity to speak with all of you today.
Thanks so much. And thank you everyone for your questions. I'm sorry we didn't have a chance to get to all of them. And Margot, I'm going to hand it over to you now.
Thanks, Donna. So first of all, thanks to all of you for being here and listening, and sharing questions and ideas in the Q&A and chat. I especially want to thank President Obed, President Karen, and Vice Chief Pratt for taking the time, for sharing your knowledge and informing us about your communities and those you serve. I would point out to the participants that there's a couple of resources here, as you can see in this slide, that will be available, that are available to you, and they can be found on the Collaborating Center website. And if any of you would like to join our mailing list, here it is, so that you can access all of these webinars, resources that people have talked about, and many, many more. So here's an opportunity for you to join and participate with the Collaborating Center. So my last words are hi to you presenters, to you participants in taking part in this third webinar of the Visioning the Future series. We look forward to seeing you again on June 20th for our fourth and final webinar of this series. Have a wonderful day. Miigwech. Hi.